Good evening, everyone, and welcome to the Health Overview and Adult Services Scrutiny Committee. Item 1 on the agenda is the fire evacuation procedure. I think we can skip that, Mr. Mulholland. Item 2, declarations of interest. Are there any? I take that as a no. Item 3, urgent business, if any. This is introduced by myself and I have not been aware of any urgent business. Item 4, apologies for absence, please.
Yes, Chairman. Councillor Abdullah, Councillor McKeon's coming in place, Sue Long and Suzanne Hilton from Age UK. Thank
you very much. Item 5 is the minutes of the last meeting and of which you've all had a copy. If everyone's happy with those minutes, will someone move they be accepted?
Move them, Chair.
All those in favour, please say aye.
Aye.
Aye. The ayes have it. Aye. Item 6 is the committee work programme.
Standard report to this meeting, Chairman, setting out the suggested items for slotting in for future meetings of this committee.
Thank you. Councillor Sherrington.
Thank you, Chair. There is something that I would like to go on the work programme, which relates to young adults. I'm just concerned because of the COVID-19, whether young adults, whether we could find out if there is a percentage greater of young adults who are struggling with either mental illness or homelessness. I think that the thing is that you'll find that there might be more young people becoming homeless because they can't actually fetch anything in, because normally they would probably be on low payments that now they probably won't be able to get jobs at the moment. And I'm just wondering whether that is the case, because we can surmise all this, but it'd be very, very interesting to see if these people are becoming homeless because of work situations, because of family problems, and whether it's affected their mental health. So the only way that we can do that is if we find out whether these percentages have gone up. So I was just wondering if we could have that as part of the work programme, so that we could have a look at it to see what we can do, if there is anything that we can do, like for instance working with agencies like Backup and so on, to see that if we can overcome some of these difficulties. So that's what I'd like to go on the work programme, if it's possible, Chair. Thank you.
Yeah, I mean, there is an item listed on the work programme about mental health, and if you and members did agree, it could be it could come back to the committee as part of that.
Yes, I'm quite happy to take on board Councillor Sherrington's request. I think it's a very valid request, particularly with regarding young people at the current time, and we'll certainly work that into and place it on the work programme. Thank you.
It's just to check that members of the committee are happy, Chairman. We'll add that on.
Are members happy?
Aye.
Aye. Thank you, members.
Aye.
Item number 7 is the COVID-19 and winter plan update. And for this item, we have Nikki Lomax for the first few slides. And then, of course, we have Fiona Noden and Joe Street, who will deal with the systems. Nikki, if you'd like to lead, please. Thank you.
Great, thank you, Chair. Yes, I'm Nikki Lomax, consultant in public health at the Public Health Team, Bolton Council. If we just move to the next slide, John, please. I'm just going to share some summary information on the epidemiology of COVID, the current picture in Bolton. I have to say, it is a challenging picture, and it's a deteriorating picture at the moment. We've seen an acceleration in the number of daily cases, and you'll see that from this graph. This is a combination of Pillar 1 and Pillar 2 testing data. It's not complete for the last 5 days, but you can see that we've had a significant rise in cases over the last 2 weeks. So it's overall not particularly good news. And this is a reflection, there's a similar picture across the northwest and spreading to other areas now. I have some new data from the Northwest Situation Report just from today. So I can give you the latest picture for Bolton, which is that we have our testing rate is still increasing, which shows there's a demand for testing, but our weekly case rate is now 556 per 100,000. That's a 33% increase in the last week. I have to say though that to give it some comparison, as I've said, we're seeing a similar pattern across the northwest. Similarly, Blackburn with Darwin have seen a 50% increase in positive cases in the last week. Chorley, 60% increase, and for comparison, Stockport and Wigan also 39% increase. Equally worrying. If we move to the next slide, John, please. Thank you. This is just a summary slide. You can see the trends over the last few weeks. That third panel, you see the weekly rates, and it's quite a jump we've experienced over the last 2 weeks. And our positivity is actually up to 18.3%. So things definitely aren't going in the right direction. We are seeing as well, if we move to the next slide, please. This is what we call a heat map, and you may have seen it presented previously. It just shows the weekly cases by age. So your top of your top band is your 0-15s. At the bottom of that this graph, you see 85s plus, and you can just see that trend as the number of positive cases is picking up in the older age groups. And also worryingly, we've seen a 41% increase in the positives in the over 60s just in the last week. So I'm sorry not to bring better news. It does overall appear to be a worsening picture. I think we just brought a few slides today. There's much more detail, and you can see trend graphs if you want to look at the JSNA, coronavirus pages on the Bolton Council JSNA. That's my summary of the COVID position at the moment, Chair.
Thank you. Have members any questions at this stage of Nikki?
Yes, Chair.
Yeah, okay, Councillor Howarth.
And also me, Chair, Mark Cunningham.
Okay, I'm not getting you on the chat box, folks, so I'm not sure.
Just having a little trouble with it at the moment.
That's right, but that's okay. That's all right.
Thank you very much.
Councillor Howarth.
Yeah, thanks very much, Chair. I want to ask, it's a public health issue I want to ask about, and it's around the engagement work. I just want to say, though, related to engagement work, I do want to say that it was really good to see reports from Health Watch Bolton earlier in the lockdown, because they've been in dialogue with the public, and they've made some recommendation to council and partners about what the public wants and what would be more helpful in terms of written material and so on. And I thought that was really good reports to read. And so I want to ask you, if I can, just find out a bit more about whether you feel as a team there are gaps in the public engagement work at all at the moment, the COVID-19 engagement work. And because it's something that you do all the time, really think about what outcomes do we want and how we might measure this. Not all services think in that way, do they? Is there anything you could say even about that, and about maybe how you sort of think at the end of the week or at the end of a few weeks? What would we want to be sort of measuring and looking at in terms of where we might want to tweak or change things? Thank you very much.
Thank you, Councillor Howarth, for that question. We had a very similar discussion at the Health Protection Board last Friday, and I think our conclusion is, in terms of comms, and I'll come on to engage, in terms of comms, we really couldn't have done a lot more. We've had a really, this has been with us for several months. We've got a really strong collaborative comms cell across the CCG, the Foundation Trust and the Council, working together all the time, trying to continually refresh the comms as well, because you know, people get fatigued with the messages, and there's, you know, with the frequency and change in messages, so they work really hard to do that, update the frequently asked questions, use the council website. I think as we acknowledge though that comms doesn't necessarily translate into behaviour change or the behaviour you need and want, and there are a lot of other factors at play. There are a lot of factors influencing people's ability to follow the guidance, as well as appetite to follow the guidance. So that's why the engagement stream is such an important one. And I'm really pleased that you know, we've had positive developments recently with the Bolton Fund, funding specific for some very specific projects. Lots of different creative projects and options that have been developed by small groups that have put forward and for grants to do that. So that's promising. We have an engagement, we've appointed to engagement officer based with CVS, who sounds like a really good appointment with some brilliant engagement and comms skills. So that's all positive. I just think we're in a really challenging position at the minute. The comms teams are working flat out. We're building engagement. I think we will look again at we've got a quality impact assessment for the overall COVID outbreak plan, and we just want to make sure that no groups are excluded, particularly the groups who may be more easily excluded, different disability groups, for example, or particular cohorts in the community. So I think we're constantly looking at it, and that's the job of the Health Protection Board to review that continuously. So I feel we're doing fairly well. There's always more to learn. There's insight work being led by Greater Manchester that I think we'll learn quite a lot from as well.
Thank you very much.
Thanks, Nikki. Councillor Cunningham, please.
Thank you, Chair. Nikki, it does sound at first very daunting, this, with the large increases that you're showing, but perhaps we maybe should we not be looking at it the other way? Obviously, since the return to schools and universities of students, we would have expected to see surely quite a large increase, and with the improvements in testing, and now we're including both Pillar 1 and Pillar 2 in these figures, is it just not, you know, should we not have expected these numbers? Is it as daunting? Because a lot of these will include surely people who are asymptomatic, you know, and hopefully won't go on to become seriously ill with this. So does it not just show that the test and trace system is working quite well?
Thank you for the question. I think we perhaps shouldn't be surprised that we are seeing greater social circulation through universities, through schools going back, reopening the economy and hospitality. We shouldn't be surprised to see that translated into more positive cases. I think the concern is the scale and the rate of them and the rate of acceleration. And you know, we're looking for positive news all the time where we can, but the concern is where we're seeing transmission now translate into the older age groups that are who are more vulnerable, and we are seeing that translate into hospital admissions, and we're seeing that trend across the northwest, and we've certainly seen that in Bolton. I know we've got colleagues at this meeting from the Foundation Trust. We're seeing the numbers of inpatients with COVID increasing, and we have seen a number of deaths in the last week. So I think that's the big concern, that the transmission is now reaching the more vulnerable groups. Thank you.
Thank you.
Thanks for that. Thanks, Mark. I can't see any more questions on this particular part, so I'm going to bring in Fiona Noden, please, for the second part of the presentation. Fiona?
Martin, I'm there. I'm on speak.
Sorry, I can't see you. You're not coming up on the meeting chat.
I've gone in and I put speak and it's come up on the thing.
No, I'm sorry, I can't see you. Sorry about that, Elaine. You're on mute.
Right, is it all right if I come in now, Chair?
Yes, of course.
Okay, thank you. Well, I did actually go on speak twice, once before and one after, but there you go. Anyway, all it is, I just wanted to ask about the graph that shows the different age groups who were showing that they've actually got COVID-19, and the fact is that you've got a large amount of red, which tends to be with the under 50s, and then you've got sort of amber coloured when it comes to the 80s and the 70s. And fair enough, it is going up slightly there, but the thing is that how do we stop the people who are younger, who are actually the ones who are getting COVID-19 more than the older ones? How do we stop them passing it on to the older ones who then die? And that's what the difficulty is. And I was just wondering, how do we get it across to them? Because I do believe that a lot of them just believe all sorts of things. When you talk to people, it's like it's not real, it's just all pretend. And it's just to keep all the North down where they deserve to be. And we've got all sorts of factors out there that are coming out of people's mouths, because quite simply, they're going on silly things on the internet, and they actually prefer to believe that because they don't want to follow the rules. So I just wondered how are we going to turn this around? Has anybody got any really good ideas? Thank you.
Chairman, can I just check that the person I've just let in, is that Joe Street I've just let in on dial-in, please?
Yes, but this is Joanne Street. Yes.
Oh, great, lovely. Thanks a lot. Sorry to interrupt.
Thank you.
Thanks, Councillor Sherrington. If you want me to comment, again, we had this exact conversation or discussion last week at Health Protection Board, and I acknowledge the challenges, and often people don't perhaps take things seriously if it doesn't affect them immediately, or their family. That's one of the issues, and I think we've talked about using more local voices and videos and stories to share that. I think we did also acknowledge that we're trying to, it's an overused phrase, but trying to perhaps change some of the narrative, and it's this feeling of solidarity we need, and cooperation, and that personal responsibility. The University of Bolton are working a lot on this with their students. It's about trying to get everyone to take personal responsibility and play their part. I think actually we know, despite all the rules and the tiers, the key containment measures are really, really simple. It's your social distancing, it's your hand washing and personal respiratory hygiene, and mask wearing now in appropriate settings. Really simple messages. We said they were the same approaches, unfortunately, back in 1918 when we had the Spanish flu. That doesn't change, but getting people to participate, to do that and keep that going is really hard, and I think that fatigue plays in, and people wanting their normal lives back. So we acknowledge it's challenging. The insight work might help. I think sharing stories might help. Hopefully, sadly, it won't be the high numbers that helps, but that's my voice reflecting back to me. But I think that's where we really are at the moment. Councillor Sherrington is trying to get people on side, supporting and doing their bit, every individual. Thank you.
Thank you. Thanks.
Councillor Donegal, you're on mute.
Sorry, I can't see any further questions on this particular section. Can we now have Fiona Noden, please, for the second part? Thank you.
Thank you, everybody. Can you forward the slides on, please? Thank you. Thank you very much. Next slide, please. So it's an update from the last month that I attended to provide you with an update. So what you've got in front of you today is a couple of graphs on the left hand side, which shows the number of patients that we've had in the hospital to date. You can see towards the left top graph, our highest level was we had 148 patients in during April, and you can see that there was a reduction. Now we're on the second wave. So our current number of patients in the hospital is 59, with 7 of those patients on critical care. The graph below indicates the number of deaths that we've have had in hospital. So the blue line is the total number of hospital deaths, and the orange line is the number of patients who sadly died with a COVID-19 positive. And as you can see, because the time is exactly the same as the graph above, there's a slight lag of where the peak is to the number of deaths. So it's unfortunate that we've had 42 people die in October to date. So we are starting to see the numbers of people dying of COVID-19 in the hospital start to increase. So to manage all of the increase in activity, we've agreed escalation levels across the whole of Greater Manchester, where we also have buddy hospitals, and we also have mutual aid for each organisation. So if organisations are starting to reach capacity, we have processes in place to be able to ensure that patients can be treated safely. Within all of this, we need to continue to balance our usual winter pressures along with the second wave, and continue to safely make sure that we can treat our elective patients. So those patients who've been waiting for either surgical treatments or for other diagnoses, we've made sure that we continue to treat those patients. And to do that, we've been using the Beaumont in Bolton to make sure that we can deliver services outside of the Royal Bolton Hospital. The capacity for the organisation across both acute and community is challenging as we enter winter. We've got workforce challenges because we've obviously got COVID sickness, we've got track and trace people who've obviously got to be shielded, and we also have the normal levels of sickness that we're dealing with. We have escalated this week our final escalation ward to be able to deal with our COVID-19 patients. So I've put some information there regarding our critical care. What's really important this time is that we haven't seen the same levels of patients requiring critical care support as we did in the first wave. Can I move on to the next slide, please? Thank you. So planning for winter, we continue to plan for winter, and as I said at last meeting, our clinical teams are far more knowledgeable about the virus and they're much better prepared. They've dealt with it before, they know exactly what they have to do this time. I can't say that there aren't levels of anxiety because of the number of patients that are coming in, but our staff are certainly in a much better position than they were back in March and April. We've got plenty of PPE, we've got plenty of stock that's available to us should we need it. We've continued to embed different ways of working. So for example, we've got video consultations, and we continue to consider how we can do drive-in consultations for some of our staff. So we've got drive-in glaucoma service, and we're looking at how we can deliver a drive-in respiratory service as well for some of our spirometry, so that how you are breathing and assess that. We've put lots of services in to support our staff. It's really important that we keep our staff well so that they can continue to see our patients and look after our patients. As I said, we've got coordinated work across Greater Manchester to make sure that we can discharge people appropriately from hospital when they have COVID-19. We've also improved our access to community midwives because we've seen the numbers of expectant mothers increasing with COVID as well. So we've made sure that those patients are safe. Can you go back to the next slide, please? Thank you. We've been developing green sites in acute organisations across Greater Manchester. So this will mean that some of our patients in Bolton will be offered alternative sites for their surgery, so that we can make sure that they're safe and we can continue to provide elective services across Greater Manchester. We have had a soft launch of 111, where we've been encouraging people to call 111 prior to attending A&E to reduce the burden on our emergency services. And we are planning for mass vaccinations once available, and that will be under national direction, but we're looking towards the end of November, beginning of December for those plans to start to be seen. So our biggest challenges are the modelling of the increase in activity for COVID-19 would indicate that the peak will be around the 9th of November for Bolton. So we need to continue to plan for that, make sure that we've got beds available, and make sure we've got an ability to move our patients safely and discharge them into the appropriate setting. The demand on urgent services continues. It's not going away, and we need to make sure that we can deal with those patients who require urgent services. We need to continue to deliver cancer patient services and elective patient pathways. There's also the demand for COVID-19 testing, both from our staff and for our patients, to make sure that we understand exactly who is positive and how we need to make sure that they are supported to be shielded. We have seen an age profile in hospital care, and as alluded to in the previous presentation, you can see that the numbers of patients who are more elderly are now starting to be affected by the virus. And all of this is increasing our length of stay. So our elderly patients often stay with us longer. So we need to make sure that they are supported to be able to be discharged to an appropriate setting. I'm going to hand over to Joe Street now. So if you can provide the next slide, Joe will talk to the next slide. Thank you.
Joe, if you need to unmute, it's *6 as you're dialing in. Thanks. We can hear you, thanks.
Can I just check, can everybody hear me?
Yes, we can.
Lovely, thank you. So I'm Jo Street, I'm Divisional Director for Integrated Care Services Division, and here deputising for Rachel Tanner, MD, for the Integrated Care Partnership. So I'll give you the Integrated Health and Care update. Thank you very much. We continue to work together as an Integrated Care Partnership through our community bronze structure, which I think Rachel updated you on last time, and through that bronze group, we are working on and being cognizant of all of the areas across primary care, community health and social work where we are beginning to see some pressures, and our resilience is starting to be tested, and we have in some of those areas enacted parts of our business continuity plans to a small degree already. We also, this week, will be responding to the Department of Health and Social Care Winter Plan. That winter plan really is a plan that's not just for social care. It really does bring together all of the elements of the system and builds on what was already in place, but helps us to bring that together into one place and focus as a partnership. Our priorities at the moment are very much focused on keeping people well at home and helping them to avoid an admission to hospital, and of course also helping people to leave hospital as quickly as they can safely do so. And that obviously is an increasing priority for us, given what we've just heard from Fiona with regards to the pressures currently being experienced in hospital. In relation to that, a key part of our system which does help people to leave hospital in a safe and timely way with some of our most complex needs, our intermediate care services. We have experienced some challenges within our Darley Court intermediate care unit with regards to the building, and we're in the process of reconfiguring our intermediate care bed-based services into other buildings so that we can safely continue to deliver those services over winter. We're also working closely and continuing to work closely with our care homes across Bolton. There's been some recent work where we have gone out to expressions of interest for care homes to help us with providing additional capacity through the winter months. And this is both in support of intermediate care, but also in support of isolation pathways, which are a requirement of us to provide those isolation pathways for people leaving hospital who need to go into a care home. All of those isolated pathway designated settings will be approved and supported through CQC registration. We are also starting to really focus our attention on supporting care homes with the reintroduction of visiting. So that will be supported through risk assessment, which will be supported by the public health team and by the infection prevention control team. And we have just in this last week communicated with care homes with regards to the risk assessment that they need to start to complete, and that we will be supporting them with in order to allow to restart safe window and garden pod or similar types of visiting. Just finally to say then that we continue our focus on trying to deliver the requirements of community and integrated services within that were set out in the NHS Phase 3 requirements. But we are starting to experience some challenges with regards to that in relationship to the business continuity challenges that we're starting to experience. So that's the end of my slide, and happy to pause there and take any questions.
Thanks, Joel. Thank you for that. Just before I take questions, and I have questions from Councillor Howarth and Councillor Cunningham, Fiona, could I just ask you a question, please? One of the things that was highlighted at the beginning of this pandemic was the support and effectiveness of the Nightingale hospitals, that should they be needed, they would be there to back up the existing provision. The difficulty I have, or I'm trying to get my head around the fact that if the Nightingale is brought into being and up and running in Manchester, it will need staffing. Now, if I take staffing away from Royal Bolton and put them into the Nightingale in Manchester, that doesn't actually help your cause in very much, really. So I'd like to hear your comments on that, please.
Thank you, Councillor Donegal. Can you hear me okay?
Yes, thanks.
Thank you. So the Nightingale Centre in Manchester is currently being re-energised, so they put the heating back on to understand whether or not it is something that we will need. Each organisation in Greater Manchester is working as part of Greater Manchester Gold escalation. The support for the Nightingale Centre will initially be provided for by Manchester Foundation Trust, and if there are any patients that do need to go into the unit, then we will be required to support those patients should it be necessary. It will not be provided. It will mainly be for patients who are non-COVID positive, and it will be a rehabilitation unit. So it will require different levels of support. So they're currently looking at how we can support it, the unit across Greater Manchester, with support from some GPs, also from therapy staff, and very few nursing staff, because these patients will be requiring intensive therapy to be able to get them home. So does that answer your question, Councillor Donegal?
Yes, thanks. And I've got Dr. Battiani who wishes to come in with a comment. Dr. Battiani.
Thank you, Chair. Are you able to hear me?
Yes, thank you.
Yes, thank you. I just wanted to make a comment on resilience in the health and care workforce. And the last slide that's up at the moment, this point has been made about resilience in some parts of primary care, community health and social care showing pressure. I think this is right across the system, really, even in secondary care. I think we just have to acknowledge the journey that the workforce have been through. Initially, when the emergency started, and incredible work was done at the time. Then, of course, as we got on top of the emergency, we then had to concentrate on restarting some of the other work in the NHS. And then, of course, we now are in the second wave. So I think it's not surprising that the workforce are under pressure. And this pressure is beginning to build. And certainly, I know colleagues in primary care are beginning to feel this quite significantly, as absence from work due to various reasons, either to COVID or to self-isolation, etc., builds up. It is becoming quite an issue. And I think we just have to bear that in mind. And the reason I say that is that we need to make sure that our public are on our side. If you go back to the beginning, when we first started with this emergency, the public were with us. If you remember, people wanted to protect the NHS. In fact, they protected it a little bit too much and stopped coming altogether. But I think that togetherness, we're beginning to lose some of that, because the number of complaints are beginning to increase, because there's frustration on both sides. People are waiting, the workforce is under pressure, and the expectations are different now, and we can't quite meet them. And I think there's a piece of work we need to do to get the public back on side, not to protect the NHS, but to work together with us to make sure that we share some of these burdens. So I just wanted to make that point. Thank you, Chair.
Thanks very much, Dr. Batiani. Now we have some questions, and the order of questions are Councillor Howarth, Councillor Cunningham, Councillor Sherrington, Councillor McKeon and Councillor Wilde. So we'll go across to Sue Howarth. Councillor Howarth.
Thank you, Chair. I want to ask a bit more about vulnerable pregnant mothers to both Fiona and Joanne, please. I just want to understand a bit more about how COVID is affecting the service and what the service is in the community, if you can tell me any more about that. And I'm thinking of the vulnerable pregnant mothers that are living at home or perhaps living in a support service of some kind. Be grateful for any further information from anyone on the call on that. Thank you very much.
Thank you, Councillor Howarth. Our work continues with our community services through our midwives that continue to support our vulnerable mums, both as they did before and as they will continue to do so. So nothing's changed for them at all there. In fact, we've been providing some additional support for our community midwives to make sure that they can provide services to those people who are vulnerable in those different settings.
Thank you. Councillor Cunningham, please.
Thank you, Chair. Question really well, it's two parts to this, but for Fiona. Having listened to the first presentation regarding the massive increase in cases and taking that all on board, and now come to the actual cases where I think Fiona said we have 59 in the hospital currently, 7 in critical care, and I think that this is the real crux of the matter, and I think it's what we what we need to concentrate on. We have, from hundreds or thousands of cases that are getting reported, it's a very small, thankfully, number that actually in comparison get into the hospital. And looking at the 59 we've got there, yes, it's always going to be a worry, and I know that there's going to be deaths involved in this, but what is our capacity, I think, Fiona, in terms of HDU and ICU beds with not Greater Manchester but within Bolton? How many do we have to go at, and where are we in terms of capacity that we've still got available, or are we near to capacity in the numbers you've already got in there?
Thank you, Councillor Cunningham. So to assure you, we have got plenty of capacity for our patients. So our critical care unit is able to escalate up to 35 beds. So as we currently stand at 7, we've got plenty of capacity to deal with those individual patients. Our capacity often is not just about beds. Our capacity is about staff, and as Wirren alluded to, the staff are our greatest asset, and we need to make sure that our staff are keeping well to ensure that they can look after our patients. So we've got lots of capacity as long as our staff are well, but it really is, if we can make sure that the public are playing their part, they are keeping distant and wearing a face mask is the most important thing to reduce the number of patients who do need hospital care. Thank you.
Thank you. And the second part of the question was going on to your winter planning, in particular the national 111 soft rollout that we've our soft launch that has started. It's not, well, you'll be aware that I already have concerns about the way people arrive at hospital or don't arrive at hospital, perhaps in a timely manner, starting back in the GP surgeries or trying to access GP help first, and depending on what happens there, if it's telephone consultations or video consultations, etc., sometimes they don't get the correct diagnosis, which delays them getting to A&E in the first place. If they're then going through a second triage, not triage as in the triage within the A&E unit, but triage over the phone or something before they can even go near an A&E unit, again, I think that also presents a second danger, and patients may not get the treatment they need in the timely manner they need, and it could undoubtedly result in some deaths that may be avoidable elsewhere. I know we need to talk about this out of this meeting prior to the GM meeting, because I touched on it last in there. But now that the soft rollout has started, what kind of response are you getting on this up to now? What kind of feedback are you getting from it?
Thank you, Councillor Cunningham. I'll start to answer the question, but I'll ask Wirren if he wants to come in as well, given your question. So 111 service is to ensure that patients who don't require urgent emergency care are dealt with in the most appropriate setting. So we have a number of different ways that we can support those patients. It will certainly help those patients who do require urgent care to get care more timely and faster, because we will be dealing with the ones that do need to come into hospital rather than the ones that don't necessarily need to come into hospital. I'll pause there because I think Wirren might want to come in and answer some additional comments there.
Yes, can you hear me?
Yes, absolutely. Thank you.
Yeah. Okay. Thank you, Fiona. Yes, I really want to build on what Fiona has said already, and the question is really quite important, and it's exercising a lot of people. It's a balance, isn't it? It's a balance of making sure that we have the right people coming into A&E, because we know from experience the number of people that come to A&E are huge, and the majority do not need to be there. The majority do not need to be there because they need to be accessing services elsewhere outside the hospital. And we've done we've spent a lot of energy in messaging, kind of getting out the right messages, and that hasn't really had much of an impact in terms of getting people to behave differently. So particularly in this COVID, living with COVID, it's particularly important that our A&E departments are not full, because they become unsafe, as you can imagine, in terms of the risk of actually contracting the virus itself while you're waiting in A&E. It has become really, really important now to keep people safe. So the issue is, what do you do? And this thing about ringing first and triaging has been discussed for quite a long time, but I think it's now at pace that we need to do something about it. The key difference now in terms of triaging is that the triaging is going to be clinically led, and the clinically led triaging is going to make is particularly important in making sure that those people who need to see either their GP or need to go to A&E are given that appointment in a very timely manner. So we may actually find that people get the care that they need more rapidly rather than actually going to A&E and waiting. So it's you know, there are pros and cons, and the soft launch will give us some early indications whether there are actually clinical risks attached to it or not, and how we deal with them, how we mitigate them. But certainly in primary care, 111 would be able to directly use appointment slots for GP practices, so there shouldn't be a delay in that. And the clinical assessment, the triage, will help to rapidly get people to A&E if they really need it. So I think it's not completely free of risk. I think we have to wait and see. And this is part of the reason why there's a soft launch, so that we don't go from one system to another too quickly, to make sure that we learn from the early start. I hope that helps.
It does, Dr. Bertiani. Thank you. I think the practices and procedures, as you've outlined them, yes, are what we're concentrating on, and it's good to hear that you recognise the need for risk. My concern came from, and I've discussed this once before. My concern came from an actual practical example. You can get people to speak to people. So it started in a particular case. It started with a patient who needed to speak to the GP, got through to a GP, and then was phoned back by a advanced practitioner. We give and prescribed stuff for stomach cramps and nausea. However, that went on for a couple of days and got worse, and then ended up at A&E. The patient ended up at A&E in Bolton. There was the usual trouble about getting in because of, rightly, the concerns of letting people in, but she was not in any real position to express herself properly at that point, having been into the third day of really suffering. Was admitted into A&E, checked over in triage there, and put onto a ward. That was early in the mornings, certainly done by 11 o'clock. And the concern had been raised that it might be something much more serious, such as appendicitis. The patient was transferred, but not seen then by consultants until that evening. So about 9 hours being lost. When the consultant came on, who realised something was really wrong and ordered an urgent scan. The appendix, of course, had been ruptured, basically spread around the insides, and other than the fact that she was on morphine for pain and IV antibiotics all day, it would have or could have been something even leading up to fatal. And the worrying bit was the triage and the doctor's notes from A&E that morning said suspect gastroenteritis, possible appendicitis, but not likely. And this is where I worry that you will lose 3 days from your GP to get into A&E, and when you get in there, the triaging isn't always done properly. And I think it is a worry. And it's a worry that's still with me, but great to hear you say that we're going to look at there could be problems and see if there are. It's not about the practice and procedures of, yes, you can refer 1-1, they can send you to GP. If you don't actually get to your GP, if it ends up being a telephone conversation, that's your first line, and we lost a couple of days there. And when we actually got to A&E, we lost nearly a full day when it was getting towards the critical phase of septicemia and stuff like that. It was gangrenous in actual fact, the appendix that burst everywhere. And I see this as a worry going forward. If we have people ringing people on 111 and they're deciding whether they ought to go or not. If that patient hadn't gone when they did go, we might not be talking about it in this light. It could have been fatal.
Thanks for that, Mark. Councillor Sherrington, please.
Thank you, Chair. What it is, a couple of months ago, I actually, as along with other councillors, I got something through from the Local Government Association regarding what the CQC was advising to care homes to actually take patients from the hospital who'd had COVID, and was encouraging the councils to pay these homes to actually to actually pay them more to actually take these residential cases on. And I had a word with Rachel Tanner at the time, because I was concerned that this might be happening in Bolton, and I was assured from Rachel that that wasn't the case, and they'd not been approached by the CQC to do this. So I've got my concerns regarding what's going to happen with these block boot beds, which are being CQC approved. I'm just a bit worried. Was it a way that they're going to pay care homes more for these beds than they normally get paid? And there is the other concern, is that if these people who are going in there are not being given the opportunity to even think about going into a different home if they do need to actually have a care home, because they've already settled themselves in to this particular situation. So I do have, that's my concerns that I have. So I'd be very interested to find out, are we paying more for these block boot beds to assist discharge? If that is the case, well, actually it's a turnaround about what people were led to believe a few months ago. And I do have my concerns about how this actually helps with the pathway of actually either getting people home to their own homes or choosing a different home for them to go and live in. Thank you.
I'm happy to come in on that. It's Joanne Street.
Thanks, Jo.
Yep.
Thank you, Councillor Sherrington, for your question. I think first of all, I'll pick up, if it's okay, the second part of the question with regards to people becoming settled in these care homes once they leave hospital. I think you raise a really valid point. It's precisely for the reason that we want to be able to give people, as they leave hospital, the time to recuperate and make really sound decisions for themselves personally around where they want to live if they do need to go through the life-changing event of moving into a 24-hour care setting. So the block purchasing of the beds is precisely to support that very focus is around allowing people that time and space to be able to make those sound decisions. And we do have a full multidisciplinary team, including adult social care social workers, who will be supporting people in those units so that we can make sure that they're fully supported with decisions around their ongoing care needs. With regards to the payment for those places, we have gone through a due diligence process with regards to ensuring quality, first of all, with regards to those placements, then also with regards to competitiveness over pricing. So we haven't got anybody on today from the commissioning team with regards to specific information for you with regards to the pricing, but they haven't been paid a specific incentive, if you like, if that's what you have heard from other areas with regards to taking this particular piece of work. And if there are any further questions with regards to how pricing for this particular piece of work has been decided, then I can certainly pick that up with Tracy Minchell, the Assistant Director in the commissioning team, who could contact you perhaps outside of the Scrutiny Committee and clarify that with you, Councillor Sherrington.
Well, thank you very much, but I do think that the Scrutiny Committee does need to know, because that's the whole idea of the Scrutiny Committee, is to scrutinise everything relating to what we do regarding care and health within the town. Thank you.
Thank you. Councillor McKeon, please.
Thank you, Chair. I'd like to follow up the questions of Councillor Sherrington and ask, when the old people are moved now from hospital into care homes, are they tested? That's my first question. And the second one is about visitors to care homes. We've heard some heartbreaking stories of relatives who haven't been able to see their elderly relatives in care homes for months, and we hear about the degeneration of elderly people's mental health. And there are calls for relatives to be allowed into care homes and to be given the status of an essential worker and tested so that they can go in and give their elderly relatives, you know, the comfort of someone they know and love. So I wonder, there is a mention obviously about visits through a window or in a conservatory. Is it not possible to go a little bit further by the use of testing? Thank you.
Thank you, Councillor McKeown. As to the first part around patients being tested, patients are tested constantly throughout their journey in a hospital and are only discharged into care homes when it's safe for them to do so, or alternatively if they are in an isolated area in a care home so that they do not infect other people or other people do not infect those individuals. As to visiting, I might ask Joe to pick up on that, and then your final comment, it might be that Nikki comes in to speak and answer the question there. Thank you.
Thank you, Fiona, and thanks to Councillor McKeown for the question. With regards to testing, I can certainly give information with regards to the process for when people are leaving hospital or also moving into a care home for the first time from their own home, from the community. And everybody who does enter a care home through those routes does have a test before being admitted into the care home, and that's obviously in order to make sure that we understand what safe isolation precautions need to be put in place for that individual person and also for safeguarding the rest of the residents. I'm going to ask Nikki to come in, if that's okay, Nikki Lomax, who may be able to answer a bit further detail with regards to the recent decisions that have been made and the steps we're putting in place to safely be able to allow visiting again back in care homes in Bolton, if that's okay, Nikki.
Yeah, that's absolutely fine. Thanks, Joanne. Just on the visiting changes, and completely acknowledge it's been very distressing for many families, and we've had letters and appeals on a weekly basis. There's some work being done by Greater Manchester preparing care homes for when the rates might fall. Quite a lot of detailed work around that, but also, as time's gone on, what the DSPA, the Director of Public Health in Manchester, have done, Greater Manchester, have got some further legal advice, which is why we've now been able to move to window visiting, because they've made the case that the length of time makes this an exception, an exceptional circumstances to support visiting, but initially to start the safest type of visiting, which is with closed window visiting. So that is the first step. There's quite a lengthy risk assessment document that has been produced by Greater Manchester that we've just issued to all care homes today, with a bit of advice saying, look, not all of this is relevant to window visiting. Please complete it as much as you can. There has to be some oversight from our infection control team and from the public health team, so we're supporting homes on that, and we'll endeavour to turn that around as quickly as we can to enable to get families in there doing the window visiting. I think there are other possibilities on the horizon for other visiting, and I can't commit myself to anything now, but I think there are the possibilities there legally, but it's a different proposition when you're talking about people going into the care homes, particularly given the context we're in, which is the really high rates of community transmission. So there's a much higher risk of taking the virus into homes. So we've got to be really, really careful. On the question of testing, testing has its limitations. It's not, no test is perfect. It's not without uncertainty. You can have false negative, false positives. So when we meet with care homes every fortnight, we constantly re-emphasise that what's critical to keep your residents safe and your staff safe is your really high levels of use of PPE and infection control measures. That's what's important. And there's a fair challenge, I think, from families about how can our visiting not be made safe, and I think that'll be the next phase of work, is looking really closely at how we might do that and how we could do that safely. But some of that's got to work through. I think we're on a journey, and I do think there's a huge commitment in Bolton across Greater Manchester to really do the best we can for families and for their loved ones and care homes. I think it is really, really difficult. And again, we can't rely on the tests. They're only good as the moment they're taken, so that, you know, they're not the answer, they're not the silver bullet, if you like. It's the other measures that are particularly important. So it is something we're working on. Really want to get the window visiting started, and that's the work that's ongoing this week. I hope that answers most of your question, Councillor McKeon.
It does, and I'm grateful and relieved to see that work is being done. I'm a little bit shocked, actually, that the doubt you put on tests. Obviously, I agree, no test can be 100%, but surely, I mean, well, I'm asking the question now, what percentage of tests can be relied on? And my final point is, window visiting is all very well in the summer, but we're moving into a very difficult time of the year for weather, aren't we? I don't think it's great to see people having a window visit in a force 9 gale. However, I'm pleased that you're making progress, and that's great, because it must be absolutely devastating for relatives not to be able to see their elderly parents and grandparents.
Thank you. Just to come back there on the tests. Every test is different and performs differently, and there's some work being done by Manchester University at the moment to look at each type of test, where it's best used. And I have to remember, I almost put 2 hats on, because I think, you know, the slide I shared earlier with the rates on general population testing, the people going, you know, in the community going to the MTUs, the mobile test units, etc. That's good enough in the wider community to allow for some of the, you know, uncertainty. They're not being perfect results always, but I think in the care homes that's a different question. It's a much, you know, more vulnerable cohort you're talking about there, so we have to be really cautious of over-reliance on testing, and hence it's really about your infection prevention control measures, your PPE, and acknowledging that we do have weekly and fortnightly testing. We're part of the national programme, not without its issues, but that gives some level of, you know, you're getting extra information from that, and it is picking up asymptomatic cases early, but we can't entirely rely on testing. If that makes sense. I can always come back and offer more detail on testing outside the meeting.
Thanks,
thank
Nikki.
you. Thank you.
Thanks for that. We're now going right across the borough to Astley Bridge and Paul Wild. Paul Wild, please.
Thanks, Chair. Yes, sunny Astley Bridge. My question is to do with the, ironically, we're just following on from the last question, the COVID-19 testing regime. I read in the newspapers and saw on television last week that Boots, the chemist, are launching a new super fast testing service throughout the chemists. I just wanted to know how effective and accurate are they, and are they valid and a recognised test? I think they're saying that they can issue results within 12 minutes, which seems very, very fast. and because of the complexity of it, and you've already mentioned that, you know, obviously it's not 100% perfect. Would Boots test come up to muster? Thank you.
Shall I come in there? I can't speak to detail of the Boots test. I'm sure it's reasonably reliable, or they wouldn't be offering them to the public use. And I'm sure you get advised on that if you do access the Boots test. I haven't done myself personally, but I mean, Boots possibly have had access to other commercial opportunities to bring in their tests that we've not had. We're reliant on the national Pillar 2 testing and our local Pillar 1 labs, but I'm sure it's reasonably good, and they should provide that information when you access their tests, if that's what you do. I think they are quite expensive at this point in time, and at the moment I have to say we do have good access to Pillar 2 testing locally. There's no need necessarily to go to Boots. We've got good capacity at our local mobile test sites at Moor Lane and at Leverhulme and Mere Hall.
Right, thanks for that. Thank you.
Thanks, Nicola. Thanks, Paul. And we go now for our final question to Mark Cunningham. Mark?
Thank you again, Chair. Yeah, just picking up on some of the things that have been said from the last speakers. I wondered how many perhaps people contract COVID whilst they're in hospital, and why perhaps, or if it would be helped if staff, and I realise there seems to be some reservation about whether tests, from what I've just heard, are effective or not, but if staff such as doctors and nurses and even the porters, people that you come into contact with, could be regularly tested, that might chop down or reduce the transmission of what could happen in the hospital. And I would link it into the thing about care home discharging people to care homes, or even into rehabilitation settings such as the Nightingale. If you're testing the patients, as we say we are, before they are discharged into these settings, and they are being treated by doctors, nurses, or wheeled around by porters and other staff who haven't been tested, between them being tested and leaving the hospital for discharge to travel onwards, they could even pick up something from hospital staff there. Are we missing something there that we could do that we're not already doing?
Thank you. I'll start, but I think Nikki might want to come back in again. So thank you, Councillor Cunningham. We certainly have had incidents in Bolton of nosocomial outbreaks, is what they're called, where patients have been infected either whilst in a bay where they infect one another, or where there is some staff contamination. Currently, so all the staff in Bolton were tested back in August when we had a ward that was closed due to a nosocomial outbreak. Out of all the 5,000 staff that we tested on the hospital site, we had 11 positive samples at that time. All those staff were then isolated and went into and continued to isolate for the 14 days. At the moment, Bolton isn't seen as a nosocomial issue, but that doesn't mean it's not gone away. Our colleagues across other organisations, so Wigan, the Northern Care Alliance and Manchester Foundation Trust, are currently all going through a mass staff testing. Ideally, we would mass staff test on a weekly basis to make sure that our staff were safe to be able to deal with our patients, but at the moment there isn't the physical capacity to do that testing. All the staff within the hospital setting are all equipped with PPE, that we all wear masks whilst in any environment with anybody else, even in non-clinical areas, so we are reducing the infection that could possibly be passed from one to another, and every member of staff wears a mask in any environment. And the most important thing is wearing a mask and keeping distance, and obviously we can't keep our distance from all our patients when our patients need their support, so we're doing everything we possibly can to make sure that our patients are safe whilst in our hospital setting and our community settings. Nikki, is there anything else you wanted to add around testing?
Yeah, just quickly, 2 points really. One on asymptomatic testing and screening. It is another tool. It's another tool in prevention, but as we've said, it's not the complete answer, and it's not always 100% accurate. So if you do it, as we're doing in care homes, where we're regularly screening all staff and residents, you still have to manage those potential false positives where there's no indication of where that transmission's come from, or even, you know, got always that risk of some false negatives to people you don't pick up, but it's an extra thing we can be doing. It's like an extra safeguard, so it's beneficial from that point of view. The faster you can turn it around, the better. So if you're doing that, you need a fast, efficient system. Just on the testing before admission to care homes or on discharge, I think that is a tricky and it's possibly more complex issue than people appreciate always. That, for example, if someone's tested positive, they may have even done their full 14 days self-isolate or isolation in the hospital. They can test positive for quite a long time afterwards, even when they're not infectious. You know, can be what they call a long tail of positivity. So that can be misleading and disconcerting for the home they're going into. And as good practice, everyone who's admitted to should be isolated on admission anyway, if possible, if their circumstances allow. So it's a complex issue, and I think I suppose what's good is that people are trying to work together to find solutions and share the right information with homes and support people, as Joe was saying, to get to the right place for them, bearing in mind there's no perfect system and perfect answer, and there are limitations with the testing. Does that help?
Yes, thank you, Nikki, and thank you, Fiona. I think I just, so that, yeah, that's great. And I'd just like to finish by echoing also what Councillor Sherrington said earlier. I think there is, it's important we don't take too many things out of these meetings to try and sort it elsewhere. It is important. We are a health, scrutiny committee, and we need to get to the bottom of whatever we need to say when we're in these settings. So thank you very much, and thank you very much, Chair.
Right, thanks, Mark. Thanks, Nikki. Okay, if we could move on, please, now to item number 8, which is the flu campaign presentation. And I think Nikki's on again for this one. So a quick drink of water there, Nikki, and then you're live again. Thank you.
Thank you. Thank you,
John,
Chair.
are you able to put the presentation up? I think you might be having some difficulties, Nikki.
Okay.
You might, if okay to start, and
can do
members have had a hard copy.
Okay, no worries. Yeah, I had a few slides to just update the committee on the National Flu Vaccination Programme for this winter. And just a reminder that the programme's commissioned nationally by NHS England. It's delivered locally by our primary care colleagues, GPs, pharmacists, and within the hospital trust. There's a schools programme delivered in Greater Manchester by IntraHealth. And obviously this season, flu vaccination is particularly important. We want to avoid the risk where we can and minimise the risk of flu transmission alongside COVID, and we want to avoid people being dual infected, and just protect people as far as possible. So the ambitions are big this year to have the biggest ever flu vaccination campaign. We are delivering this within the constraints of COVID-19, so it's a bit tricky with social distancing and use of PPE. And importantly, there are 2 phases to be rolled out. I still don't think I've got the slides, but phase 1 is your regular cohorts. The committee's probably had presentations before. There is a slide in your pack that lists the usual eligible cohorts, particularly those aged 65 years and over in long stay residential homes, the child programme I've mentioned, and health and social care staff, very important in particular. In addition, this year we have a phase 2 that hasn't been triggered yet. This will depend on vaccine supply, and this will include household contacts of those on the shielded patient list, children in year 7, actually that's going ahead now, 50 to 64-year-old age group who will be eligible, or they'll be invited to be vaccinated when and if the supply is available, which we hope it will be by November, but we wait for national confirmation. And this season, an inactivated vaccine may be offered to children whose parents refuse the nasal spray, which is the usual childhood vaccination, due to porcine gelatin content, which is important to some of our community here in Bolton. Again, that's subject to vaccine supply. Really important around the vaccination of key health and social care workers, all eligible for a free jab. If you are at the hospital, they've got their flu-a-thon and they're pursuing everyone, because I think the target is 100% uptake. For most cohorts, still challenging target, 75% uptake is what we're aiming for. Just an indication there's a massive interest in flu this year, in having that vaccination. By the end of September, which is really early, normally last year there were 10,000 vaccinations done. This year was up to 52,000. Pharmacies seen a 3-fold increase in appetite, in numbers coming through for vaccination. So it's all looking promising. That is the good news from me tonight. I have a further slide which just summarises how we organise ourselves through the strategic flu group with all our relevant partners to enact our flu vaccination plan. We report to Health Protection Board. That group is meeting fortnightly, so they're really on top of it and reviewing activity and seeing how the uptake's going. We know that practices have run some really big flu clinics and been held up as a good example in doing mass vaccination. And I mentioned pharmacy. We're also working with BCOM to look at targeted uptake in Muslim communities, and that's across all groups, not just the children, but older age groups, at-risk groups, and other faith communities we'll be working with. I have to pay tribute to the CCG, who their comms team lead, working with the other comms leads in the council and the FT, but they lead on all the comms material and assets, and they'll be using everything this year: social media, radio, interviews, big digital billboards, everything. It's just gone live this week. And we've got our Flu Fairy, Flow the Flu Fairy comms is going again, and we do promote flu through our regular webinars with care homes and on the schools webinars. So just an indication. We've started there with the first slide, but I've pretty much summarised what's on the slides. A lot of activity. We are seeing already the over 65 uptake is looking very good. It's looking less good at the moment for the at-risk groups under 65, so we're going to be keeping a close eye on that and really liaising with practices in particular, because the recall work is what is particularly effective there, and really practices pursuing people in those younger age groups to come and have their jab. So a lot of activity going on, and I'm happy to take any questions from the committee.
Thanks, Nikki. Our first question, we're going over to Tongfold, to Councillor Elaine Sherrington. Elaine Sherrington, please.
Thank you, Chair. Well, I must say thank you very much, Nikki. You've actually answered what I was going to ask, which was regarding the percentage of people who are taking it up, because I know that you've got all these groups that are entitled, but I was just wondering what the percentages were. But you've actually answered that, so thank you very much. Okay.
Thanks, Elaine. Thanks, Nikki. Any further questions, please? I'm not getting any indication, so thank you very much, Nikki, for that presentation. If we could move on now to our final presentation this evening, and that's from Dr. Warin Batiani on the BAME community, and particularly the inequalities that exist within that community and how we are addressing those. Dr. Batiani, please.
Thank you, Chair. So I don't know whether you'll be able to see the slides or not, but I think we all have got copies ourselves.
We can't at the moment, but they've had them in advance, yes.
Okay, so I just want to start by saying, listening to the discussion and the questions and what's going on currently with COVID-19, it's pretty clear that it's a very complex situation. We don't know enough about the virus. We're learning all the time. It's raised a huge number of questions, and we don't have all the answers yet. And this issue about the impact of COVID-19 on our BAME communities is another example of the complexity of this virus. So first, Chair, I just want to thank the committee for giving me this opportunity to talk about this issue and challenge that we have. So why are we talking about BAME and COVID? You know, when the emergency first hit us, we saw on our screens on TV about the number of deaths that were occurring. We then started to see the number of deaths that were happening in our medical workforce. And to give you just a bit of an idea of what we saw or what we have seen, I'm at the moment just focusing on the workforce, of health and care workforce, to look at some data just to bring this issue to understand it properly. You know, nationally, 44% of our doctors are from a BAME background, but actually they have accounted for over 95% of the deaths in terms of just the medical workforce. If you look at similarly, if you look at our nurses, 20% of our nurses are from the BAME background, but actually they've accounted for over 64% of deaths. This is quite remarkable, these statistics. And we know this virus, of course, is having an impact on everybody. But the evidence is such now, is so compelling that we know that it is having a disproportionate impact on our BAME communities. And why is it having this disproportionate impacts? We don't quite know fully why, but there are a lot of things that we have to consider. We know that in the BAME community there are coexisting morbidities, like diabetes, like heart disease, like blood pressure, and so on. We also know that the BAME communities have certain issues in terms of inherent inequalities in our society. We know there's the thing that's driving this issue at the moment are things like housing. We know that housing can be multi-generational. We know poverty has an issue that we need to consider. We know that occupation, I've just talked about the health and care occupation, but we need to think about things like taxi drivers, for example, thinking about a hospitality sector. We see the BAME communities are disproportionately involved in those type of occupations. But we don't actually have all the answers yet, but we know deprivation again plays a huge part in this. So when I talk about BAME communities, I don't like to talk about just BAME, because I know the same issue happens in all our deprived population as well. So I tend to think of BAME and our deprived communities together, because the same problem is there for all of these people. These are the communities that are being left behind, and there are plenty of wards, as you well know, where deprivation is a significant issue and health inequality is a significant issue. So I look at that as a whole, not just BAME. So in your slides, the thing that I want to really focus on is, well, what are we doing about it? I was involved in this BAME issue because of two reasons. One, as you know, my background is primary care. I'm a GP by background. I chair the CCG and I lead the equalities work in the CCG, and our town leadership, the ACP board, asked me a couple of months ago, would I look at this issue and do something about it? And but in Greater Manchester, I also lead the equalities work, and I've been asked by Greater Manchester to do exactly the same thing. So I've looked at it from 2 points of view, really. One is the workforce. We talked about the issue when Fiona was doing her presentation. It's really important that we keep our workforce safe so they can deliver the service. The second part is our communities. So in terms of our workforce and the data that I showed you about the disproportionate deaths, it was really imperative that we started doing something about protecting our workforce. So in GM and Bolton, I'm really proud to say that we were ahead of the curve in taking this on and doing something about it. So what we have done is, in terms of the hospital and primary care workforce, we have risk assessed every single person, not just BAME, but every single person in primary care, in our GPs and in our hospitals. Every single person has an individual risk assessment. This is an individual conversation where people have looked at their comorbidities, their age, etc., and attached a risk. And if the person is at higher risk, then we've mitigated that risk by first taking them out of that situation, doing things remotely, or giving them extra PPE, etc. So every person has had that. And I'm really proud to say that our hospital, the RFT, really got on to that really quickly. and our primary care did exactly the same. And now over 95% of our workforce has been risk assessed, and that's really, really good. We should be proud of that. So community engagement. When we talk about community risk, you know, I was involved in a regional piece of work as to how can we reduce community risk, with a particular focus on BAME and the deprived communities. So this is where our community engagement has played a massive role. So I'll talk a bit more about that as I go through the presentation. And part of this community, protecting our communities, is how we're going to make sure that first we understand the situation. So we must monitor our services. We must make sure we have ethnicity data. So, you know, in Bolton, you may know that we have a Bolton quality contract for primary care. And part of this quality contract now is everybody with a long-term condition must have their ethnicity recorded so that we can understand the size of the problem. And despite all the challenges in primary care, what we're saying also in the Bolton quality contract is people with long-term conditions must have an assessment. And this may not be necessarily a face-to-face assessment, but at least even over the phone, so that we know that's just how they're managing their long-term condition. If there are issues, then of course we must bring them in. That's become part of the Bolton quality contract as well, targeting this long-term condition. We've already had the presentation about the flu vaccination, so that's really, again, a key part of this. The other thing is actually establishing leadership. So every organisation, particularly in the NHS and care organisation, has been asked to nominate an equalities lead to make sure that they get a grip on this and understand the situation. So for the CCG, I'm that lead. For Bolton, I'm that lead, working together with our partners and our public health colleagues, of course. And every practice in the care networks that we have with practices, they also have an equalities lead to make sure that we're all working together. So that's really strengthening the leadership. So moving on to the next slide, I want to talk about this new thing that we started in Bolton. This is the BAME Alliance. Now, everybody's familiar about BAME. The R at the end stands for refugees. This alliance is really partnership working and engaging with our communities through this partnership. And we see in our presentation on the slide the partners. The partner that's missing from this slide is Health Watch, because Health Watch have been very keen to be part of this, and then they now are, of course. So we've got the BSCA, we've got the NHS, the Council, the CVS, Bolton at Home. Everybody has come together to address this particular issue. So what do we want to do as a BAME partnership? We want to share communications, key messages. We want to pool our local resources and our money. We want to develop an understanding, and we want to learn about this so that we can do things better. Next slide, please. Can you move on to the next slide?
I can, just 1 second.
So this is you know, this BAME Alliance partnership is very much new, and so far we've spent quite a significant amount of time in engaging with our communities. And this was a question that was asked earlier about engagement in Bolton. You know, we have to be so proud of the engagement that has happened by working together. Actually, you know, people are getting message fatigue at the moment with the amount of engagement that we've done. So what we're learning from this is we really got to start doing it in a slightly different way. We've done lots of webinars, lots of leaflets through the newspaper, radio, etc., etc. Next slide, please. And can we move on again, please? And part of this engagement is we've been able to start to identify community champions in our communities, because we know that our communities respond to messages and to information from their own leaders. So we're developing message champions. We want to train them. This is where public health, Bolton, has played a major role. And we've created video content. But I think we now need to learn from this and move on to the next phase, because we're in the next phase of this COVID, and we got a little bit of fatigue with messaging. You know, we have such a lot of restrictions on us that people are getting quite stressed up about it. They don't really want to be told what to do again and again. I think what we need to do now is to start to say why we need to do this. It may sound simple, but actually, if you explain why we need this tight restrictions, people might engage better. And we've also done a huge amount of work with our university. As you know, when the university opened and we got this influx of students, both in Manchester and here, there were some issues, but the university has done a huge amount of work in making the university safe, COVID safe. But of course, the key thing is what happens outside the university. So in terms of engagement, I'm really happy that that we've really done a really good job. And I think Bolton should be proud of that. I think the key thing is now to understand where we go next with this BAMER Alliance and how we start to do something more about addressing our inequalities, which are really entrenched both in GM and in Bolton. And this is the sort of discussions that I'll be having with our partners as to what the next step is. So I'm going to stop there, Chair, and take any questions or any other comments.
Thank you. Thanks very much, Dr. Battiani, for that presentation. I have some questions. Councillor Sherrington, Councillor Dean, and Councillor Howarth. Councillor Sherrington, please.
Thank you, Chair, and thank you, Dr. Battiani. I don't know if you remember that 2 years ago, me and you had our flu jobs together, so that when I was mayor, to try and convince the rest of the town to go out there and do the same. However, we've moved on a little bit since then. We've got this COVID-19, and what I was going to ask you about is I was watching what was happening in Leicester on the television last night, and of course Leicester's been at a bit of a bad time earlier on, and now they're back in having difficulties again. And it was Diwali, and the temple was closed for Hindu celebrations. But what they'd done is they'd actually opened up the temple as a testing place. And I'm just wondering whether, if we actually had the mosques and the temples and any other organisational religious place to actually go and be tested, because most religious places are in the centre of communities, and whether we add those as testing stations, it would be a good thing, because if we decided, or the government decides, that they're going to take a different route to actually stop this COVID-19, if people are used to going to a particular place to actually either get information or are tested for anything or immunisation, if it was done in them communities, those places that they're familiar with, then it would be more helpful in the long run. So I was just wondering whether we're going to take Leicester's lead. That's all it is. Thank you.
May I respond to that? The first thing is, Councillor Sherrington, of course I remember you. Of course I remember having my flu jab with Madam Mayor at the time. So really nice to reconnect with you. You're absolutely right. These things, we have to take these opportunities, because communities work best in their communities, and all these things are open. And the key thing in Bolton is that we have really good relationships with our communities. both with BCOM, the Hindu Forum and so on. And all these things will be taken into account, and people are coming forward and offering their estate for all kinds of things. And I think, and you know, when we continue with the flu vaccination, we've done the first cohort, the at-risk people, and then we move on to the second cohort, the younger people. The logistics of this are going to be quite difficult, and we will probably have to look at these community assets to make sure that we work with them, to make sure that we get these people vaccinated.
Thank you, Doctor. Thank you.
You're muted, Councillor Donegal.
Sorry, thank you, Warren, and thank you, Elaine. Can we go to Councillor Dean, please? Madassa?
Thank you, Chair. Thank you for that presentation, Dr. Batiani. Absolutely fantastic piece of work. I think it's the beginning of a lot more research that's going to take place, but it's good to see Bolton and Greater Manchester at the forefront. It has been something that's been highlighted nationally, that you know, the BAME population has been affected more, and it's just good to see our town, this partnership, working together on such an important issue. So congratulations on that, and keep up the good work. My question is that, do you feel that there are particular parts of the BAME community, and BAME itself is diverse? You know, there's people from all sorts of different backgrounds, whether they're Afro-Caribbean, from Southeast Asia, from the Indian subcontinent. Do you feel that there's any particular, through your experience so far, do you feel that, number one, there's any particular BAME community that is affected more than others? And number two, you mentioned a number of illnesses or issues within the BAME community, for example, the diabetes, the high blood pressure, heart problems. What I wanted to ask is, one of the things you didn't mention, do you feel the vitamin D deficiency could be one of the issues as well? Thank you.
I think that's a really great set of questions. In terms of which part of the BAME community, you're absolutely right, the BAME community is very, very diverse, and in Bolton and GM it certainly is. But when we look at the statistics in terms of which part of the ethnicity group is particularly at risk, top of the list, I think I may be corrected here by our public health colleagues, but the last time I looked at the statistics, the black community was number one, closely followed by the Muslim Asian community. So this is why when we look at the BAME Alliance, we make sure that we cover all different parts of the ethnicity spectrum. So, but you know, we have to take all of these groups together, and all of them have their own particular different cultural backgrounds, the way they work, the way they perceive things. It's all really important, and we're beginning to learn in health and care that culturally adapted offers are really important. We have to understand these different communities and understand their cultures in order to engage with them. And this is something that we're learning all the time. I think the other part of the question was, sorry, I've just forgotten the second part. Can you just repeat that for me? Because I did have the answer to that.
Yeah, you mentioned a number of sort of health issues within the BAME community. Do you feel that the vitamin C deficiency,
yes,
vitamin D deficiency is one of the issues?
Vitamin D is something that's been looked at in quite some detail. For a start, we know that people of darker skin normally have a deficiency of vitamin D, or a higher risk of having a deficiency of vitamin D. And when people looked at those people who were seriously ill in hospital, well, a lot of them did have reduced levels of vitamin D. And a lot of them were elderly, and a lot of them were from BAME communities. So you could sort of argue that, well, there's vitamin D low levels, and we've got this BAME community, and you can, but you know, that evidence is circumstantial. It's not a strong set of evidence that vitamin D deficiency definitely puts your risk up, but we know there's an association. So the way we are responding to that with our workforce in our communities is saying, first, it is a good idea to take a vitamin D supplement anyway, because we know, particularly with the winter approaching, with the restrictions that we have, we're spending more time indoors. So please take vitamin D supplements. It's important. And if you're at high risk, when your risk has been done, if you're in the BAME community, for example, our GPs should have a lower threshold of testing for vitamin D, because sometimes if you test them and your levels are very, very low, then supplementation is very specific in terms of dosage. So if you're at high risk, one shouldn't feel shy about asking your GP to test your vitamin D. So, you know, the advice is take vitamin D supplements. There is evidence associated with high morbidity and death from vitamin D. And we have a low threshold of testing for vitamin D at the moment. I hope that helps.
Thank you.
Thanks, Madassa, and thank you, Dr. Batiani. We now go across to Sue Howarth for a question. Sue, please.
Thanks very much, Chair. I've got some comments to make and then round that off with a question. Sorry, I'm going slow, but there we are. I'm always told to wait for that red line. I mean, part of our scrutiny role is to look at some national issues and how Bolton is affected by national matters. So the first thing I do want to say is that if you wind the clock back a bit on probably when we were in lockdown and it was becoming very clear, certainly about the deaths, as Dr. Batiani has set out, about healthcare workers, for example, the higher percentages, the very sad situation that we've had. There's no question that the local authorities wanting to do work, wanting to deep dive the data, the population data on Black and Asian minority ethnic communities related to COVID and so on, they were held up. I'm sorry to say they were held up by the government. That information did not come down. That delayed activity, we were just so reliant upon that. The other thing I would say is that I went to a meeting this morning actually, and the health came up in it, and the census data came up, and you know that does form part of population data that gets used in local government. And it reminded me, thinking about that today, that data is not right. And there are some relationships to some of the matters about BAME communities, because data ends up being important when people want to consider what's happening, what people's experiences are in health and care. And one thing I was reminded of is that the Somali population are not appropriately considered and recognised yet in the census data. And that's just one example tonight for people to understand that, you know, not just in our town, in other towns in England, there's a Somali population. This is one example. There will likely be other examples of this where the data that we use, the England census data, possibly UK census data, isn't it, doesn't recognise a number of matters pertaining to minority communities, and that's wrong. That needs to be sorted out, and we look to government to assist with that. The other thing I want to echo, I know it's been mentioned already, but I want to just say a bit more on this, is that yes, the key thing that has been a standout is how the ethnic data, what ethnic group we're in, relates to other things like whether there is a degree of deprivation in people's lives, whether they're living isolated lives, and all the rest of it, and also the economic data, what jobs people do. And what we found in that data is that men and women working as security guards, as taxi drivers and chauffeurs, as bus and coach drivers, as chefs, as sales and retail assistants, as lower skilled workers in construction and processing plants, and men and women working in health and social care at all different levels, very senior medical consultants, frontline care workers. This has been an utter tragedy. This is the COVID tragedy, because there has been higher death rates. And I'm moved when I say this, I'm afraid, because I know people in Bolton who have lost relatives who and friends, absolutely not all old. So, it's a moment to say that this is very hard for the families in our towns, in our borough. And from that, I think the question I want to sort of get to is that in moving forward on this agenda, how about this as lines to go on and perhaps give me some feedback on? So we must at least not create any new inequalities. We must not increase existing disadvantages, but that is going to be very hard as we're in an economic downturn. I recognise that. And we must not, I think this gets forgotten, we must really avoid increasing any existing advantages. That can be hard, but we should do that. And in order to do that, is it not that we need to get these matters about inequalities onto the agenda of decision-making bodies? And that looks like what BAMER is doing. We have a very senior general practitioner in Dr. Battiani. But I'm thinking about Bolton Vision, doctors' committees, health and social care committees. Isn't that surely one of the answers? It's got to be on these agendas. Thanks so much.
So, Councillor Howard, I need to respond to that by saying you're absolutely right in what you said in all your comments. And I can assure you that equality is very much on the agenda now. It has come up the agenda, and both nationally, Greater Manchester, in our locality, it is absolutely top of the agenda. But the thing is, what we've got to do as a borough is to get beyond the rhetoric. Getting beyond the rhetoric is the key step, and that is a bold step. And some of the things that you mentioned, if you really want to do that, and that's why I'm here, that's my great passion really, because we have such entrenched inequalities, and COVID is making it worse by the day. There's no doubt about that. So I think if you're really serious about getting beyond the rhetoric, we as a borough need to have it as a top of our priority. That means realigning resources. That means not just talking the talk, but money has to follow that. When you talk about our deprived wards and our housing and our opportunities, and I'm afraid some of the racism that exists, we have to tackle that head on. So I would very much welcome any support I can get to take this work forward.
Thank you, Sue, and thank you, Dr. Battiani, for that. I have a question from Councillor Mystery and then a final question from Councillor Peter Wright. Councillor Mystery, please.
Thank you, Chair. Just a couple of questions. First of all, Councillor Dean has already touched on the question that I was going to ask you, but what I wanted to know was when you talk about engaging with a larger community PME alliance, it appears to me that there are only a few groups that you have touched in when there's a wide range of other groups within Bolton that could be part of your community champions thing that you're looking to do, But what I really wanted to know at this particular is slightly go away from the issues of COVID-19 and go back to your clinical commissioning role. But I wanted to know, recently I've been asked by loads of people within the community, as well as some of my constituents, is about seeing the doctors, and recent, I think, headline news were that doctors do have a contract to see the patients face to face, and they might be breaching that contract. Is there, I haven't seen much change in that, because people still complain that they are struggling to get the appointments of the doctor. And I want to take this opportunity today. Again, it's part of the health and scrutiny thing. I would like to say that I want to know what, how far you've actually moved on to address that particular issues that were raised nationally, as well as, within Bolton as well. And in one of the things that you have also said in your strap lines, while still in infancy, BM Alliance will strive to build on collective efforts to date and to strategically respond to much larger scale. It's a broad statement to make, but I hope that you will work to include all the diverse, not just one section of the community, to be able to deliver the BMR agenda. Thank you, Chair.
So really important points there. The first thing I would say is that if there are any gaps in terms of our engagement, then I would like to know, because I think it's important that we don't miss any part of the community. So you know where to get in touch with me. So if there are gaps, please get in touch, because I definitely don't want to leave any group behind. But I personally felt that we had covered and talked to most people. But if there is a gap, I want to know about that. The second, equally important point about are GPs closed in terms of face-to-face. I think this is a really important issue, because if you remember initially when I talked about the resilience, and I talked about the incident of complaints that are coming up and the public losing trust in the GPs, and actually there have been many instances of some serious abuse against GPs and their practices, not just in Bolton but nationwide. And I think the perception appears to be that GPs are closed to face-to-face. They were never closed to face-to-face. They were always open. But what has changed is that you can't walk into a practice. You have to first go through a telephone triage, and for the right reasons, so that we make sure to protect the public as well as the workforce, to make sure the right people are seen face-to-face. So face-to-face has never been closed, but I think there have been some issues where some people have found it difficult. And when we hear about this, we do what we call incident report these issues, and we then talk to, if people tell us who the practice is, we as commissioners of primary care actually talk to that practice and give them that feedback to make sure that actually they don't put up barriers from face-to-face. But it's important that first people need to telephone in order to keep themselves safe and to keep the workforce safe as well. But general practice has not closed down. And, you know, if we keep on saying that they're closed to face-to-face, this is what creates the mistrust in our public. So if people have an issue with the practice, we need to know, because I promise you, we talk to that practice, because that shouldn't be happening. It's contractually not on. So general practice has never been told to shut down from face-to-face. And I can tell you the face-to-face appointments are actually mushrooming at the moment, and the demand is going up hugely. So if you know of any practice that is refusing a patient after triage, a face-to-face consultation, if it is appropriate, the CCG would love to know about that, because we will talk to that practice. I promise you that.
Thank you, Dr. Bhattiani. Thank you, Cham. And our final question, we go across to Councillor Peter Wright. Peter Wright, please.
Just waiting for the red line. Thank you. This is Dr. Bhattiani. You may have touched on this previously, so I apologise for asking the question. You said about 40% of doctors are from the BAME community. Well, what the BAME doctors, porters and nurses are at the front line. What is being done? Is there anything being done to monitor their health and make sure that they are keeping safe? Thank you.
Yeah, yes, absolutely. So when I talk about workforce in the health and care, I'm not talking just about doctors and nurses. This is every member of the staff. So when we talk about doing a risk assessment on the workforce, that means from the porters, from the security staff, to the nurses, to the ancillary staff, to the consultants, to all healthcare workers. And similarly in primary care and GPs, every single member of staff has been risk assessed. So it's not just doctors and nurses, everybody that's involved in health and care from the point of view of our hospitals and our GPs and the community services. And I think, you know, Bolton is way ahead in terms of this compared to the rest of the country, because we started while people were still waiting for recommendations. We didn't wait for recommendations, we got onto it immediately. I hope that helps.
Yes, it does. Thank you.
Thank you, Dr. Battiani, for those most in-depth responses to quite penetrating questions. We now move on to item number 9, and this is members' questions. There was only one question. Councillor Howarth exercised her right under Standing Order 36 to ask a question and has received a most in-depth response. I'm just wondering, Councillor Howarth, are you content?
Yes, Chairman, and all members have received a copy of the question and answer as well on email.
Thank you.
Thanks very much, Chair. Yeah, standing orders gives me an allowance to say a few words if I've submitted a written question. And the first thing I want to say is I know we've not necessarily got officers or all the officers involved on the call, but I do want to say that this question is about this subject called long COVID. Yes, all the members have got, you know, the question and the answer already. They've seen that today, I believe. But long COVID was a standout issue for me. You know, this is people who live in the Bolton Borough who have had symptoms of COVID, had some treatment, the acute symptoms have changed, gone away, if you like. But we hear testimony that people are then month in, month out, having difficult lives. They have different types of symptoms and their lives have become problematic, and they are still describing themselves as sick and low energy and so on. So I thought it important to ask what we have in terms of community services and even specialist follow-up and checks for people who are in this position. And I think the answer is very thorough. I think it gives me a lot of assurance that people involved acted early, got together and made some good plans and progress on this matter. So thanks very much, Chair.
Thanks, Councillor Howarth. Our final item on the agenda is the minutes of other meetings relevant to the remit of our committee. And there is one meeting, the Executive Cabinet Member Adult Social Care and Health, that was held on the 5th of October, and you've seen that. Will someone please move that be accepted?
Chair, move it.
Is that agreed?
Yes, second that.
Agreed.
Aye. Thank you very much. That concludes the business of this meeting this evening. It only remains for me to thank all our health professionals who have joined us this evening and answered some quite in-depth questions, which I welcome from all members of this committee. The next meeting of this committee will take place on the 15th of December, and please goodness, by that time we will be in a different place and hopefully in a better place, and we will be hearing some better news regarding this terrible pandemic.
Amen.
I wish everyone who has to travel home a safe journey home. If you are already at home, please try and stay safe, and I hope to see you all again on the 15th of December. So good evening to one and all. Thank you.
Thank you, Chair.
Thank you. Good evening, all. Good night, Chair.
Thanks, Joe.
Thank you. John, can you end the live event, please?
Hi, Chair.
Bye.
Thank you.
Still seem to be live at the moment.
Sorry.
We're still live.